Right, no, I agree. I mean, I think that it's interesting. There was a trial called Pertain, which is testing this very topic. It just finished accrual, and so Pertain was basically you could actually have paclitaxel for a couple months before, but then it was aromatase inhibitor with trastuzumab, aromatase inhibitor with trastuzumab, pertuzumab, and that trial is actually ongoing. Probably will announce about a year, 18 months. We'll figure out. Then hopefully that'll be on guidelines. And the insurance companies won't reject it.
The upfront treatment was pertuzumab based?
Yeah, all the upfront treatment.
It's really, does pertuzumab add if you give hormone therapy?
It's a great question. And that's really, and it's an important question to ask, to be honest with you.
So
really, and I'm going to ask everybody, I'll turn to Terry first on this one. Hope kind of hinted at this. And what is the proper way to test for HER2 in 2014? He's laughing because we're all laughing. I mean, everybody, no one knows the right answer now. So what is really the right answer?
I don't know if I have the right answer. I mean, we run into this almost on a daily basis as well. And nowadays we're finding out some things where you give neoadjuvant therapy, and then, for example, we had cases where we didn't get a good response. We tried to put the patient on the Catherine trial. Central testing comes back and the patient will be HER2 negative.
Right.
So what do you do?
On the residual disease?
No, on the upfront.
That you thought was positive?
Yeah, but somebody thought was positive, that was tested, on the outside, and you see the patient, but let's remind everybody that, when we did the adjuvant trials, we selected patients based on, peripheral laboratories that were approved laboratories, but we called positive anybody had IHC 3+, or anybody that was FISH positive. And some patients were one or the other. And at least in the adjuvant trials, we've seen benefit from both these categories of patients. In fact, we've seen benefit anecdotally from an analysis that we did in patients that were neither positive.
That's really
and that led to the conduct of the B47 trial, which is accruing well and is going to finish at the end of the year. So we're going to answer this question, whether less HER2 expression gives us benefit from Herceptin or not, or trastuzumab or not. But the guidelines vary a little bit in terms of what is the ratio and what you consider positive. Is it just the ratio, or is it the copy number of HER2 as well, which now is also a factor for positivity? And I don't think anybody knows the answer to these questions, because there's never been a trial to show if you take all these people, let's say with high copy number but negative ratio or normal ratio, are they going to benefit from trastuzumab?
And normal IHC.
Normal IHC. Yeah. So I think we had this discussion on tumor bodies. I think at the end of the day, we treat based on whether an approved and a laboratory says somebody is HER2 positive either by IHC or FISH, then I think the patient deserves treatment. And if you find out by another laboratory that is not, then I think you get into a situation that I don't know.
Who do you believe?
Yeah, who do you believe? Essentially, would you deprive the patient of the treatment? Right. And the other thing is sometimes response to neoadjuvant chemotherapy may not be totally reflective of response to micrometastatic disease. So maybe the correlate there, for example, the patient I'm referring to had very high ERPR positive, had a small tumor, actually relatively small, 1.5 centimeters, but it was HER2 positive, so we gave her neoadjuvant TCHP, and did not really respond at all. But it was still a small tumor. We took it out, non-negative disease. And then trying to put her on a Catherine trial, and obviously the patient now has HER2 negative disease based on our central testing.
I wonder if some of that has to do with heterogeneity across the tumor bed, because of the patients who drove the development of a very large randomized trial, B47, looking at trastuzumab in HER2 normal early stage breast cancer, those patients were HER2 positive somewhere.
Somewhere, yeah.
They all had a HER2 positive test, but centrally they were negative in several times. But we don't know, and we've actually had this huge email conversation about some patient that was emailed out, Cyber Tumor Board, in the last day, where Antonia Wolf weighed in and sent numerous paragraphs about the ASCO-CAP guidelines. But it was actually really interesting to hear, because I think that the place where I get stuck, isn't so much the copy number of 6 or greater. So I figure high copy number, okay, got that. Truly HER2 positive, old criteria, got that. But then there's this group of patients who have a ratio of 2.01 or 2, something like that, and they have a copy number that is less than 4, but their ratio is still 2 or 2.1, and those patients now count as positive.
Right.
And so the question in my mind is, we're doing the ATTEMPT trial, which is looking at weekly paclitaxel and a year of trastuzumab versus TDM1, trastuzumab emtansine, for a year. Will TDM1 work in somebody like that? That's the question. We have no idea. And then you might not be giving them the right therapy. So it's an interesting question. And Sarah, I don't know what you do with those patients.
Well, I mean, I think the data with TDM1 is suggesting now analyses on all the studies of TDM1 have looked at mRNA levels, greater than median or less than median, associating with progression-free or overall survival. And it is suggesting strongly that expression of HER2 means a lot in terms of determining sensitivity to
So expression by
TDM1.
RNA of HER2?
That's how they did it in the various analyses in the phase 2 studies. And
Yeah, because none of us really use RNA in the
no, it was
clinic.
RT-PCR is the way that they did it for this particular analysis, which may be problematic. But I think what I heard someone say earlier is giving the patient the benefit of the doubt. You wouldn't want to deprive a
That's
patient of a relatively non-toxic therapy
right.
if part of the tumor is indeed HER2 positive. And so I would tend to treat even if one of those parameters is positive and meets the guidelines.
Well, you're making a good point, because when you report a FIS, you only count so much. And if you have a FIS ratio of, let's say, even 1.8, that means that some part of the tumor have ratios of more than 2, because it doesn't work any other way. This is just an average.
But TDM1 is dependent on
how much.
On how much. And
really
so
neat. That's
one of the
that's
questions
excellent
is,
point. Right.
is adjuvant TDM1 going to work in that setting? Obviously, this is a very unique situation. You could just choose not to randomize those patients. But it does bring up a question. You have a patient with bilateral breast cancer. One is ER positive, HER2 negative. I have a real patient like this. And one is ER positive, HER2 positive, strongly HER2 positive. Gets randomized based on the HER2 positivity in I-SPY 2, our neoadjuvant multi-center trial, to receive pertuzumab and TDM1.
So we have the same
Without
sort
any
of,
hormonal therapy.
No, that's the neoadjuvant therapy. Then they get AC. But to get pertuzumab and TDM1 for 3 months in a patient who has one tumor that's HER2 negative, I didn't put her. I took her off.
but that particular
Well,
patient wouldn't
necessarily.
necessarily.
Score on the other tumor, and if it's
That's
low,
right.
then
If
you
it's
have
low,
to treat.
no, it was a high risk, 30.
Oh, well, then.
And the other tumor is probably, unless it was a very high-grade ER-positive tumor, you're not harming the patient by waiting. I mean, the Christine study, which is also a neoadjuvant study, has a TDM1 pertuzumab arm, and the comparator is TCHP plus TCHP. And then after surgery, for those patients who have residual disease, who are in the TDM1 pertuzumab arm, are allowed to receive standard chemo because of this concern of heterogeneity and that possibility. So I still wouldn't have an issue with treating that patient you described with TDM1 pertuzumab.